Hi, I'm Sue Mays. I'm a senior lecturer at Trobe University, and this is...
I'm Ebonie Rio, so I'm a sports physiotherapist at the Australian Ballet and the Victorian Institute of Sport, and I'm also an embedded research fellow at the Australian Ballet.
So we're here today to talk about posterior ankle pain, and I'd like to ask Ebs, what is the sort of most common source of posterior ankle pain? Because I feel like we see a lot of Achilles tendinopathy diagnoses. So is it prevalent, and do you think it is the main cause of posterior ankle pain?
It's a good question. I think it's overdiagnosed, and I think the reason it's overdiagnosed is we rely on things like palpation and imaging. Now, palpation and imaging have a place, and it's probably most valuable in terms of ruling things out. So if it's not painful to squeeze the Achilles, it's actually unlikely to be the Achilles. But if it is painful, it can still be a lot of other things. Same with imaging. If your imaging is completely normal, it's very unlikely to be the Achilles. But if you do have imaging change, it's only a risk factor. It can still be asymptomatic pathology. But because research around the world has traditionally used palpation and imaging, and so have people clinically, a lot of people with different types of posterior ankle pain have been included in Achilles tendon research, and I think that really limits kind of the value that we can take away from it.
Okay, so let's deep dive into this. What are the types of tendon loads? And we've got a great sort of slide here. Can you sort of run us through the types of tendon loads, because maybe that will help us sort of get a bit of better understanding about how we diagnose?
Absolutely. Okay, so we have 4 different types of tendon load. When we're talking about high tendon load or high tensile load, it's about rate of loading. So you can think of your Achilles tendon like a spring, and for it to be high tendon load, it needs to be fast. Mm-hmm. But this is actually why you can see Achilles tendinopathy throughout the lifespan, because while you use your Achilles running and jumping as a spring, when you step off a curb or walk downstairs or change direction, you still store and release a little bit of energy. So you can see quite a heterogeneous group of people with the condition. But we need to think about whether or not the person in front of us is talking, that rate of loading. So a good example would be if someone has pain cycling, it can't be the Achilles because you're not using your tendon like a spring. Now, our second load is compression. Mm-hmm. So compression is where the tendon's squashed against the bone. For the Achilles, it's when you go into dorsiflexion. So that's why people with insertional Achilles don't like being in bare feet. They get into compression earlier. They prefer to be in a shoe with a heel. It's why they don't do well with the eccentric program off a step. It's because of the compression. Now, lots of tendons are compressed near the insertion, but not always. So tib post is compressed around the medial malleolus, a long way from its insertion, but it's where we see the pathology. The reason I think compression is a really important load is you can recognise and remove compression and really help people's pain. Our third load is combination. That's when we're combining our fast spring load from a compressed position, so it's pushing off from dorsiflexion. This load is a really good reminder, I think, that we can't just give people isometrics or eccentrics or heavy slow resistance. We actually have to rebuild the spring and get people tolerant to compression, because that's life, that's function. And we've got one more load. So our last load is shear and friction. So that's when the outside layers, the synovial layers, slide and glide over the tendon. So they've got lots of different names. So paratenon for the Achilles, tenosynovium for tib post and FHL. A bit of an umbrella term is the peritendon. Mm-hmm. And it's loads like cycling that I described before, or rowing, or swimming. So it's that low load sort of repetition. So we've got our tensile load, our compressive load, combination, and shear and friction.
Okay, so some of those, if we understand those loads better, then it might sort of indicate what sort of pathology we might be dealing with.
I think so. I think you can work out, is the person in front of me talking about repetition load? Are they talking about spring type load? We can also then take that through into our objective assessment. So you can start to get some clues from the subjective, but absolutely use this information when you're assessing.
Great. So let's talk about tendinopathy then. So the loads, some of the clinical presentations, and then differentials.
Sure. So for the Achilles, we've got 2 presentations. So we have our mid portion, where people point with 2 fingers either side of the mid Achilles. There isn't pain spread in lower limb tendinopathy. Glute med is a bit of an exception, but for the rest of our tendons, the pain remains quite focal, which is really interesting, even if they've had it for a really long time.
And you're talking about intratendinous.
I am,
Yeah.
yep, absolutely. So for tendinopathy and intratendinous, it's quite focal. For the insertion, they point with one finger, usually to the lateral calcaneus because it's a slightly bigger bump.
Yeah.
So our mid-portion Achilles, the load is spring or tensile load, and then our insertion, it's the combination.
And as they increase their loading, it doesn't spread, but would you expect a change in pain?
Good question. So tendinopathy, it's associated with a warm-up phenomenon, and we don't really understand why, but again, it's a really nice clinical question because that can help differentiate from some of our other conditions like, peritendinitis. So tendinopathy warms up. So we ask for the features of, are they doing high tendon load? Is the pain really focal and does it warm up? That would be my 3 sort of clinical features.
And I know that you've worked with Miles Murphy and you've actually found that stiffness is an issue. Can you talk to that?
Yeah, stiffness is a huge issue, and in fact people cited that was a really defining feature of whether or not they felt that improved, more so than pain, and perhaps because it warms up. But that morning stiffness or that stiffness on waking and how long that lasts tells us whether or not your tendon was happy with what you did the day before. So pain during activity, or even how long it takes to warm up, can be a little bit misleading, and that's why I actually don't use a pain monitoring tool during activity, because some people will be sore at the start and get nervous and underload. Some people will warm up and do far too much. So we really want to educate our patients and athletes that it's that next day stiffness, and they can time that, but most people have a pretty good idea as to whether or not it's similar to the day before.
And are we expecting that morning stiffness to reduce as we rehab, or are we happy just with stable?
Little of column A, little of column B. It can take a long time to resolve. What I like to educate people is that it can take a long time, and we're after low and stable. So if your symptoms are low and stable the next day, that's a happy tendon. So as your load's going up, we want our stiffness to be coming down, but it can be quite persistent.
Okay, great. So I think you've touched on some of this education already. Is there anything in this slide that we haven't talked about?
Well, we talked about high tendon load and it being fast. So the converse of that is we can actually immediately start people with safe loads. So people don't need to rest, even if they've got a really, grumpy reactive tendinopathy. They can safely start with slow or static loads immediately. So we don't need to rest. So we can really reassure people, but also empower them, because exercise is the mainstay of treatment. And so if we can get them going early and get that buy-in, I think that can really help with adherence down the track. The other key thing to educate people about is that how it looks on imaging or the pathology won't change. So that's not actually our clinical target. What we're trying to do is improve pain and dysfunction.
So would you ever image?
Re-image or image?
Image to start with and then re-image?
I don't, but most of the people I see sort of come with their imaging, and then there's a fair amount of kind of education around that in terms of what it means. You've got to think about what you're imaging for, knowing that you're likely to see asymptomatic pathology. If you're, I say to students, if you weren't thinking tendon before the imaging, don't let that change your mind. That's the first thing. If we're looking at it for differential diagnosis, then you probably need something a bit broader than an ultrasound. You're probably looking at something like MRI. Imaging can help pick up plantaris, but also we can pick that up clinically, and same with the peritendon. So I don't use it, and it's actually not included in the recent sort of consensus documents.
Yep, fantastic. So if it's not the Achilles, what is it? What are the other differentials that we need to think about?
Well, there's lots. We can think about the sural nerve. So the sural nerve runs lateral to the Achilles. They can have pain along that lateral border. They can have some referral into the back of the heel. They're provoked in dorsiflexion, so then you'd go through and check all your neurodynamic tests. It can be something higher up the chain that can drive that, or like a local kind of peritendon that can nudge the sural nerve will bother that as well. We can have our plantaris and we can have peritendon structures as well. So with the peritendon for the Achilles, their pain's quite diffuse. And we said before about tendinopathy warming up. You can see peritendons in people that play court and field-based sports or run, and you think they're spring activities. They are, but this is where the warm-up phenomenon really helps you. So if you have a runner that doesn't get pain until 5 kilometres into a run, as they start running, their calf is sort of maintaining that quasi-isometric foot strike. As they fatigue, they go through more range of motion and they overload the peritendon. And so, this would be something that I would imagine with your extensive ballet career, you would have seen a few of these because of the range of motion they go through lots of the different foot and ankle tendons.
So this is that shearing that you're talking about.
It is.
So we definitely see it with FHL. So it's really rare to see intratendinous FHL changes. Usually it's tenosynovitis, and I think I see this misdiagnosed a lot too. So people don't appreciate that it's the sheath that's getting friction and compressed. So it frictions with the movement, but it also gets compressed behind the posterior talus. And so people are sort of giving them a tendon rehab, whereas they actually need to think about that range of movement and those sort of shearing and compression loads.
How do they present? Where's their pain?
So there's this idea that it's just sort of medial through, but that definitely can be posterior. So the FHL sits very posterior in the back of the talus. So initially it's actually quite posterior, and it's only when that sheath starts to fill up with some synovitis or swelling that it actually starts to go medially. So I think it can be often missed.
I agree, and I think I forget how posterior it is until I remind myself of the anatomy. Yeah, it is very posterior. It sits right behind the Achilles.
So do you think there's a difference in managing peritendon versus a sheath of a FHL or even tib post?
So I think we don't understand a lot about the pathology, but as best we know, the crepitus that you hear, so a stethoscope can be a really valuable tool actually for picking that up, both in the diagnosis but the monitoring. The adhesions between the tendon and the sheath, it's the conversion of fibrinogen to fibrin. So it's not the classic, if you strain a muscle and you have that triphasic inflammatory response, it's like this kind of chronic process with this exudate. And that's why the treatment or the target is the anticoagulant. It's actually the heparin. So we know as physios we can't tell people to do this, so they need to work really closely with doctors or pharmacists. But the heparin and Voltaren wrap, the active ingredient is actually the heparin. So that blocks the conversion of fibrinogen to fibrin, and the Voltaren actually improves the absorption through the ion channels. But I think I can't name any literature that's looked really closely at the differences between FHL, tib post, Achilles, even de Quervain's. We're still trying to understand it.
Because FHLs tends to be that synovitis, but they both really respond, I think, to the gel wrap.
I think they do.
Can you explain just for everybody what that involves?
So it's a combination of the hydroid cream and the Voltaren gel, and people mix it together and gently slather it over the affected region, so the Achilles peritoneum or around through FHL or tib post, and then they glad wrap it on overnight. It can be quite, sensitive skin can break down a little bit, so people need to be careful. And again, you have to work with the doc because there are contraindications, so it's not for everyone. People tend to need about 7 nights worth of treatment, but if your skin's breaking down, you can do it night on, night off. But interestingly, people often feel better after a few nights and then go back, and it kind of rears its head again. It can be really persistent, and some people need a couple of bouts worth of treatment. So. But it's also not a magic bullet. So if you're not removing the provocative load and removing the shear and the friction, people will say it's not doing anything.
It's just an adjunct.
Yeah, that's right.
I guess one of the key things about a sheath irritation is that unlike a tendon where you can kind of get them through, you really have to lock them down. Like they just definitely get worse as they go. And I think we just need to really stop them and really settle it down well.
100%. They don't do well with the general, be active, exercise is good for you. And unlike a tendon, we actually need to target the pathology. So and that's by removing the provocative load, which is movement, plus or minus, the cream wraps. But yeah, if we don't lock them down, you chase your tail.
Now, another condition, your retrocalcaneal bursitis. Can you explain to everybody how that could be affected and what sort of pathology that's involved in?
So the retrocalcaneal bursa is part of the enthesis. So we can think of the insertional Achilles, the calcaneus, and the retrocalc bursa as being completely as one and related. So what we don't want to do is think of the retrocalc bursa in isolation and forget that we've got this insertional Achilles. And so, you know, we would want to avoid things like just, you know, cortisoning the bursa and not dealing with the compression associated with the insertion. It's actually the same with gluteal tendinopathy. Gluteal bursitis, gluteal tendinopathy, same condition. So the retrocalc bursa is part of that enthesis and really needs to be respected as an enthesopathy.
Whereas the superficial bursa can be an isolated
100%.
condition.
Okay, so the superficial bursa or the calcaneal bursa is not part of the muscle tendon unit. So if we work our way, we've got skin, superficial bursa, tendon, calcaneus, retrocalc. Enthesis is here, and then superficial bursa. Its provocative load is external compression or friction from footwear. So, you know, some of our boots or some of our shoes that have quite a firm kind of heel cup can
And
provoke
also
them.
that sort of shape where the shoe sort of really tucks in.
Yeah, I've
It's
never
crazy.
understood that.
And even like we see it also with if they do their shoes too tight on top, we
Yes.
sort of get that extensor tendon sheath and it gets quite squeaky, and you know the moment you hear a squeak or a bit of crepitus, it's definitely locking them down.
Yep.
But also look at those sources of compression.
Yeah, that's right. Do you see it with any of the dancers, like point shoes? Was that ever an issue with the superficial bursa?
They actually get really quite swollen if they wear it really tight, but it's actually not that symptomatic. But yeah, they get quite a lot of swelling, some callus formation around the back if it's sticking in, but they can definitely sort of make sure they've got, you know, ribbons that are not too tight and elasticized, you know, contraptions that they attach just to help ease that pressure. But yeah, it's pretty rare that they actually are symptomatic, but maybe they've built up some tolerance over years of sort of wearing the shoes.
That's true. Soccer players and football players, because they like wearing their boots so small, it can be a really big problem too. And the whole generation of people that don't know how to undo their shoelaces and kind of shear their shoe off the back of their foot. Yeah.
So now we're going to have a look at this progressive loading protocol that Bruna Tezerin actually has popped on YouTube, which is awesome, that we really use to help us differentially diagnose some of the structures. So can you talk us through this?
So if we're doing a non-weight bearing repeated plantar flexion, dorsiflexion, we want to think about the loads that the different structures are seeing. So as we point the foot, we're going to be compressing, you know, the posterior ankle and some of the structures like the FHL, but because we're also going through movement, we're going to be shearing those sheaths and those peritendons. When we're doing this movement, again, we can think about the movement and the sliding and gliding load. We can also think about the compression of the Achilles tendon against the insertion. And would that bother a posterior impingement?
Yeah, you actually get stretching and of those irritated structures at the back of the ankle. It's not all about plantar flexion.
So as we're going through these tests, not only can you think about the load, you can actually start to ask people where in the movement they get pain, because that's really valuable. Similarly with this, we're doing shear and friction load. You'll note the metronome. So the 60 beats per minute means we're well below loading tendon. So these are all low tendon load tests. So if people are getting pain at this point, you have to be thinking
It's
joint,
not the tendon.
peritendon or sheath, but it isn't going to be the Achilles.
So then the sort of structures we'd see would be sheath and a bit of posterior impingement at the top of that range.
Yeah, so again, asking them where in the movement they feel it. So you want to know, do you have any pain 0 to 10? If so, where? Pain location's really valuable.
Yep.
You know, if people are, you know, showing you the whole tendon, you want to be thinking peritendon, or if they're vague or diffuse. Again, with this test, we're low tendon load, because we're not doing anything that's using the tendon like a spring. We are compressing at the bottom of that movement, and we're also moving our sheaths. Now we're starting to add some speed. Now, pulses can be a great way, particularly if you've got people that can't jump and hop.
Yep.
You can actually test the tendon by doing pulses. So what would this provoke?
Well, I like the mid-range because we're sort of eliminating the posterior impingement part of it. So it's not going to be too bad for a joint. She's aren't going to like it because of movement. And then that's where asking where their pain is and is it spreading is the key thing. So if it's staying, you know, just between the fingers, we're thinking tendon. If it's spreading, we're thinking more the sheath.
Yep. Now we can move into our double leg jumps. And again, we're going to ask the same two questions, or the same three questions. Do you have any pain 0 to 10? If you do, show us where, and then where in the movement. You'll note that people can jump and hop a bit differently. Some people go through a lot of range of motion. And this is where the progressive loading test is really valuable, because if you have someone with a peritendon, you'll get some clues in the subjective around the shear and friction. You know, you might have used your stethoscope, but also when they jump and hop, how much pain they get is actually dependent on how much range of motion they go through. So they might be provoked by the calf raises, but if they're jumping and hopping and keeping a fairly sort of fixed point, they might have the same or less pain. So that progressive increase in pain severity as you go through more tendon load is a really key feature.
Yeah. And we've got the little hop there without any ankle movement. I think that's really crucial because you'll have athletes that sort of keep quite a stiff ankle, whereas a dancer will go through that full range of movement. So as soon as they hop with that ankle sort of really fixed, we can be a bit more sure that we could probably rule in Achilles.
Yeah, agree.
But sort of not be concerned about joint or sheath if there's no movement.
Yeah, absolutely. If people are, you know, hopping like an elephant, you know, you can also cue them to hop like that to force them to store energy in their Achilles tendon to really expose whether or not you think it's the tendon.
Yep. So we might jump to some images. So this is just an image to show like really how deep that FHL is on that image on the left. So it's very posterior. And it's got quite a lot of potential for compression through there. We've got some clinical tests then to sort of really see if we can compress those structures at the back of the ankle. But I wanted to talk about imaging because the problem is a lot of...
I want to go back to the clinical test. Can you talk us through? So at uni, we learnt the whip.
Yeah.
Just talk us through the posterior ankle impingement test.
So the whip's just a yes or no, and it's pretty provocative.
It's brutal.
So it's brutal. So we really want to be careful and go into that range of movement very slowly, and you can actually grade it. So you can grade it for the amount of your own sort of compression that you're applying, because it's the very last thing in a posterior impingement case that's going to be pain-free.
Oh, that's
so if
handy
you're
to know.
just saying yes or no, and that's the last thing that's going to reduce, they're not going to feel like they're not improving. So
it's like
grading
palpation pain in a tendon.
Yeah.
It's not useful.
Yeah.
Whereas this is useful, but you need to grade it. Can you just talk us through where the pressure is for the test for the posterior impingement?
Yeah, so you're really trying to compress that posterior ankle. So the hand on the forefoot's not doing too much. It's really that compression and shearing through that posterior part of the joint that's key. Then we might look at FHL. So you can actually palpate it quite effectively, but you really need to get much more posterior than probably what you'd think. And where I've got my thumb is the spot that tends to really get inflamed and compressed. And then I also like to look at the subtalar joint, because the subtalar joint I think is often the source of some swelling around the back of the ankle. And once they get swollen, then they start to get pain with impingement.
Yeah, right.
But I think one of the problems is that people go, you know, have ankle pain, see the GP, they get an x-ray, and they find this little os trigonum, and then all the focus is on this extra bone. I mean, it was always meant to be there, it just hasn't fused for some reason. So we've done a study with dancers and fast bowlers of their front leg, which you know, often is painful, and really found that there's quite a high prevalence of one of these os trigonums. But also we looked at this Steeder's process, which is elongation. So both of those would cause impingement. And what we found was the athletes, the male athletes, had a 90% chance of having one or the other.
Oh, wow.
and 50-50 chance in the dancers and the female athletes.
And any relationship with symptoms?
Absolutely no relationship with symptoms. So I think before they get imaging, it's great to have that discussion about what we might expect, because once they've seen it, it's really hard
it's hard to unsee.
unsee. Another source of symptom could be where the synchondrosis, so that the osteogonum's joined by this cartilage bar that could get irritated. But again, we found no relationship with symptoms, but it could be potentially a source, and perhaps in an adolescent, just like the severs or the Osgood slatters, maybe it's a source of symptom, when they're growing, before it's actually fused. And unfortunately, that's when they're about 15 is usually when they're off to see the doctor for ankle pain, because they've actually ramped up their load. So there's potential that it hasn't even fused yet.
And how common is surgery, and what do you think about surgical removal for these?
Yeah, so it's very common, and they're operating on children. So we wouldn't operate on a severs or a tibial tuberosity, but they'll readily go in there and remove this potentially extra bone in the back of the ankle. Usually it's just pain that they might have when they're 15. It's very easily sort of settled down with good rehab. And we haven't had to operate sort of at the company for over 20 years. So it is something that can be managed non-surgically.
I think that's really valuable, because you're right, we see that on imaging and then they're off for a referral.
This is an image of a 35-year-old principal dancer who had a sudden onset of ankle pain after really doing a very tricky roll. And so we got him x-rayed. The reason we got him x-rayed was because of his age. So 35 is old for athletes and dancers. And so we were just wanting to clear that he didn't have sort of early osteoarthritis. So we're pretty happy to see that his joint looks good. But this big lump of bone in the back of the ankle was highlighted. Now, if we hadn't explained to him before he had his image that we're expecting to see ossicles and bony bits and pieces, so these ossicles, you can see one in the front of the joint as well, they're just really common in older athletes. And when I say older, anyone above 30, probably as a result of sort of chronic synovitis and just the ageing joint. So really these are incidental findings, totally expected in that age group. And again, if you explain to them before they have the imaging that we're probably going to find these things, it's a lot easier than to educate them on, what is really the source of symptom.
And as you say, judicious use of imaging, but also being really thoughtful around, does that imaging explain their clinical symptoms and or not? Is it just an incidental finding? It's interesting, that some of those joint changes are common. We can also see calcific deposits in tendon, and the way I explain this to patients and athletes is, if I'm a cell in the body and I see lots of lovely tensile load, I'm a tenocyte and I make tendon. If I'm a cell in the body and I see lots of lovely compression, I'm a chondrocyte, I make cartilage. If we have a tissue, if we have a tendon that's exposed to lots of combination load, the best tissue we actually have in our body to deal with that is bone. So it's just evidence of load. It's just a load-related change. They don't need surgery. They do really well with conservative management, and they're fine. And
we see that in ligaments and tendons. It actually you can see hypertrophy or even bones. So a dancer's second met will have high bone density because of the load. So it's not necessarily a negative adaptation.
No, absolutely.
So finally, this is an image of some swelling in the back of the ankle, and so we've got the ankle swelling and then we've got subtalar joint swelling, and I think certainly subtalar joint synovitis can be sort of overlooked. It can be, basically the swelling doesn't stay in the joint, it squeezes out the back, and that can cause posterior ankle pain, or it can even squeeze into that sinus tarsi and cause anterolateral pain. So it's definitely worth really investigating to see if the subtalar joint or the ankle joint is the source of that posterior ankle pain, because again, if we're treating joints, it might be quite different to how we'd manage tendons.
Absolutely, and this is quite common after a really big ankle sprain, and sometimes what happens is they have an MRI after a while, but people then see the peroneal tendons are lit up, and actually we should be looking at the joint, because it's more the joint that's giving them their symptoms.
And from the ankles I see, I definitely think that probably the majority are joint related. So is it really, so we've got sort of joint, tendon, sheath. Do you think how important is it to differentially diagnose between these conditions?
Critical. Even if I just compare Achilles tendinopathy and Achilles para-tenon irritation, if I have someone with Achilles tendinopathy, I'm absolutely giving them calf risers, whereas that is their provocative load if it's the sheath. So we have to make sure we're listening to the person that comes back that's worse, having had calf risers, really be thoughtful about what other structures it can be, but I think it completely changes our management.
And even the prognosis. So, tendon's going to take a long time because we've got to do those really small increments. We need to give it a couple of days between each loading, whereas joint, they're resilient. You can sort of throw loads at them just about every day in a row, whereas a tendon, you need to give it a break. So that sort of means that it is going to take longer for a tendon than a joint.
And that education piece is really important for people, so you're setting their expectations.
Yeah. And then even sort of their level of participation in their activity. So as we've said, tendons, you can kind of keep them going. Joints, we can definitely keep them going. They hate rest.
Yeah.
So the last thing we want to do is rest a joint, whereas a sheath, we're absolutely locking them down.
100%. Yeah.
And then what about, so we've got jumping loads versus sort of torsion and shear. Do you want to talk to that? And because that could change some of our sort of return to sport as well.
What do you mean?
So I guess with shear and torsion, that's definitely going to affect the joint.
Yep.
But does that affect a tendon as much? Are you more concerned with sort of the jumping loads?
More concerned with the energy storage loads, yeah, definitely.
So with a joint, I'm going to really make sure they're doing lots of straight line and then gradually build in that torsion and change your direction quite, later on in the end. Whereas actually joints sort of cope with the jumping load. So I'm going to keep that going, but keep out the torsion.
Yeah, that's really interesting. Yeah.
And then what about anti-inflammatories?
So anti-inflammatories cross the blood-brain barrier, so you'll get a little bit of analgesia for most of these, but we know tendinopathy is an inflammatory, and we also know even in the peritendon that the driver of symptoms appears to be more that fibrinogen pathway. So they don't tend to give us a lot when we're talking tendons.
And then cortisone, how do you feel about using that?
It's definitely not it's not without risk, and it's not something that's commonly used in the people that I see. When it is used for a sheath, for example, it works because it kind of knocks out the tenocytes actually, as opposed to the anti-inflammatory pathway. So it sort of shuts down the tendon cell activity, but it's not a go-to.
Yeah. Whereas perhaps with a joint, it's not going to be our first thing, but if we really hit a wall and we're not progressing, then the joint does respond really well to cortisone.
Absolutely.
And we've actually, I wouldn't even inject around a sheath these days because often the sheath communicates with the joint.
Yep.
So even if I'm pretty convinced it's like FHL sheath, I'm going to go for that joint underneath it and see if there's a little bit of leakage in there. But I think it's a lot safer. To do the joint.
Yeah.
So to finish off with, can you just give us a bit of an idea of how you'd load these tendons?
So following on from what you said about, joint, it's really good to be thoughtful around what the provocative load is. So if we're talking the insertional Achilles, for example, or the plantaris, the provocative load is compression or combination. So what we can do is remove all of the, work into dorsiflexion for the calf, but removing all the sneaky compression. So stopping people from stretching, or if they're going to the gym, making sure they're not doing anything with their knee over their toe. So we don't have to completely rest, we just need to remove the provocative load.
Great. And how would that vary from sort of a joint issue when you're loading?
So the joint, I would again remove the extremes of range because, as you said before, they're often provoked in that dorsiflexion and provoked in plantar flexion. So you might do more mid-range work with them. Things like the stairs can be really valuable.
Yeah, fantastic. Well, that's great, Ebs. I think
fun.
We've covered quite a bit in a short period of time.
Lovely to chat.
Great.